Welcome back to Behind the Drapes. I'm your host, Kenny. Today we have a very special episode. In today's episode, we're going to be talking to Dr. Fred Rotenberg, who is ready for retirement. After around 40 years of service to the Department of Anesthesiology at Rhode Island Hospital and Merriam Hospital, Dr. Rotenberg is moving on to bigger and better things. But before leaving, we're going to recap his career and talk about all the major highlights and how he got to the point where he is today. From all the residents at Brown University, I want to say a sincere thank you to Dr. Rotenberg for the impact that he's had on all of our training and taught us lessons that most of us will never forget. At the end of the episode, you're going to hear us go through all the Fred Rotenberg-isms that he'll be remembered by. When you go up to the EP lab or you talk to different surgeons and different nurses, you can tell that Dr. Rotenberg is very loved and very appreciated in our hospital. It's a sad day, but an exciting day for Dr. Rotenberg to get to retirement and get to go golfing and skiing and spending more time with his family. Without further ado, let's see what's been going on behind the drapes with Dr. Rotenberg. Go ahead.
I've got some things I can talk about, including my research from way back when I was an undergrad and then a grad student and then a resident. So the stuff goes way back.
Okay. I think the first thing I want to ask you about is, how do you think the Patriots put themselves in a position to make the playoffs this year?
Not relevant, but I think the defense has to do the yeoman's work.
Do you think they're going to make the playoffs this year?
No.
But
that's okay.
What do you think the key is for next season?
New offensive coordinator and new quarterback.
I could see it happening.
I gotcha.
All right, take me back to your research days then. Where did you go to undergrad?
Let's start even before that. I started but let me start before that. After high school in 1968, I joined the Coast Guard Reserve, and I became a hospital corpsman. So my first exposure to medicine was it was like an LPN essentially, as a hospital corpsman in the Coast Guard. And I started that in 68 and stayed in the Coast Guard Reserve for about 10 years throughout my college career and into graduate school as well. And then in undergrad, which I was at WashU in St. Louis, I got very lucky. I got involved in some research at the medical school as a junior and senior in college. And I was doing research on pulmonary hypertension and the effect of the prostaglandins in pulmonary hypertension. So I did a dog study where we created surgically created pulmonary hypertension with a Blaylock operation in dogs, and then asked the question, does indomethacin affect that creation of pulmonary hypertension, which in fact it did. So this was just before the whole prostaglandin and closure of patent ductus came out.
How were you measuring pulmonary pressures at that time?
Pulmonary vascular resistance, and then we did pathology on the dogs as well. It was chronic administration of indomethacin, and I compared that with antihistamines, which didn't do anything. So we had a group of control animals, indomethacin animals, and chlorpheniramine maleate, antihistamines, and showed that the indomethacin increased pulmonary vascular resistance and made the pathology worse, the pulmonary hypertension worse. But that never got published, which was unfortunate because I was a college senior at the time and I was fooling around too much. But anyway, that was my first introduction to research, which was really very exciting and great.
What made you so interested in the heart at a young age?
Vasculature, cardiovascular pharmacology and physiology. Yep. And continued to be interested in that for many years, obviously, since then. Then I went to medical school. Before medical school, I was getting a master's in pharmacology, and I started that at University of Rhode Island. And my master's thesis was on the effects of caffeine on cardiac irritability or arrhythmias. And what I showed is that and this was in the rat population. I did a rat study where we gave increasing doses of caffeine orally to rats and then assessed whether or not it affected their ventricular fibrillation threshold. In other words, how much current it needed to cause arrhythmia. And I showed that caffeine acutely did increase the risk of tachyarrhythmia in the rat in a dose-dependent fashion. And then I asked the question, well, what about chronic administration? And I found that chronic administration reversed that effect. And in fact, the animals became tolerant to the caffeine and then actually became less susceptible to arrhythmia with chronic caffeine, which I later then showed was related to downregulation of the beta receptor because it had to do with, I did an isopaternal dose response curve to look at heart rate, increases in the heart rate with isopaternal. And that effect was blunted in the chronic caffeine rat. So that was
Awesome.
my graduate school work. And then I went on and I worked at the Lown Lab in Boston at the Boston School of Public Health. Dr. Bernard Lown was a very famous, I think he's still alive, by the way, very famous cardiac arrhythmia cardiologist. And I did research there in his lab looking at clonidine and its effects on cardiac arrhythmia. And again, that reduced the risk of tachyarrhythmia related, and this is in the dogs, related to autonomic nervous system stuff. So for many years, I was interested in autonomic nervous system and arrhythmias and cardiovascular physiology and pharmacology. Anyway, should I keep going?
I have a couple questions just to
Okay.
refer back to the research that you did regarding the dogs. And originally, how were you calculating pulmonary cap wedge pressure? Was somebody floating a swan in these dogs?
Yes.
Wow. Okay. So they would place probably a right-sided IJ, cordis,
I
and
don't
then
remember that, to be honest. This was back
okay,
in 1973 or 72. So I don't remember
fascinating.
exactly how we measured pulmonary vascular resistance, but we calculated pulmonary vascular resistance.
Okay. My next question was going to be with the rats. How were you monitoring EKG? Was it like electrodes
So
that you're able to place on the
a
chest?
surface EKG. I got some pictures I'll send you related to that master's thesis on
Mhm,
caffeine.
mhm,
But it was a surface EKG. We did an open-chested model of a rat
mhm,
and stimulated with electrical current and determined how much current was necessary to cause the arrhythmia.
mhm.
And as the caffeine rats showed, they needed less current to cause the arrhythmia, and so they were more susceptible to the arrhythmia.
Wow, incredible. And how would you inject the rats?
PO. I gave them oral.
Oh, okay.
I remember for 2 years I was going to the lab every night to feed the rats caffeine or water, one or the other. And
How
the
did this
chronic
affect how did this affect your caffeine intake?
didn't change it a whole lot.
Did you drink coffee?
Yeah,
Okay, okay. So you didn't see any concern for cardiac arrhythmias within yourself at that time?
no. But
No.
I was just curious about whether or not, because everybody said caffeine was bad for people with arrhythmia, and it was not well founded, and there was not really good literature on it. So that's why I wanted to study it.
Fascinating. And then go ahead. I think you were just about to get started about your medical school career now.
Right. So then, so that research, I was getting my master's in pharmacology, and I was working on my PhD, and that's when I was working up in the Lown Lab in Boston. And that was pretty neat. I really enjoyed that. There were some really amazing people at the School of Public Health and at Lowndes Lab. Anyway, so after that, I went to medical school, and in medical school, I didn't do a whole lot of research. I was basically doing just the typical medical stuff. But my first introduction to anesthesia was actually at the Miriam Hospital because I was a fourth year or third year medical student. And I remember Dr. Kathleen Hittner was the anesthesiologist who I spent some time with then. It was a 4-week elective there. And I remember getting very fascinated with the whole practice of anesthesia, and I really enjoyed it. So I decided that was one of the reasons I decided to go into anesthesia. But the other reason I went into anesthesia was my wife convinced me I didn't want to be a cardiologist because my other thing I was going to be was an invasive cardiologist or an EP doctor.
Uh-huh.
But this was before EP was in existence. EP really didn't start till probably the 90s.
Hmm.
Um,
How did your wife convince you to out of cardiology?
so she said her grandmother would call her cardiologist in the middle of the night, and she didn't want any people calling me in the middle of the night to bother me.
That seems like a reasonable request.
So she talked me out of cardiology and talked me into anesthesia. And I went along with it because I thought it was a great idea based on what I did at the Miriam. I actually spent an interesting month out in Northwestern. I was looking for residency slots when I was a senior medical student. I went to Northwestern to their anesthesia department and had two episodes that were uh, remarkable. I would call it that. One was I was involved with a patient who had a dermabrasion. This was back in the old days where the plastic surgeons would do a dermabrasion, and the surgeon said, "Don't tape the tube in because I have to, work on the whole face." I said, "Yes, sir." And he
Uh-huh.
said, "Don't worry. If the patient gets extubated, I'll reintubate the patient for you," because my attending had already walked out the door.
Uh-huh.
I said, "Okay." Sure enough, the patient gets extubated. I run around to the head of the bed, reintubate the patient, and my attending anesthesia comes in and says, "What's going on?" And I said, I was like shaking my boots because I was like a fourth year student, didn't know anything about anything.
Uh-huh.
And I said, "Well, fortunately, we reintubated the patient because the patient got extubated." He said, "Oh, good work." So that scared the crap out of me, but I decided based on that anesthesia was a lot of fun.
Uh-huh. That's amazing.
And then another story, a similar story, I was taking care of a patient who had quadriplegia and was having what's it when you have a sympathetic discharge,
Uh-huh.
autonomic hyperreflexia.
Reflexia, yeah.
So the same attending who was with me that from the other episode said this is a drug called nitroprusside. He said if the patient really gets hypertensive, we'll give him this drug nitroprusside. I said yes, sir. So sure enough, the patient got really hypertensive. I drew up nitroprusside in a syringe straight out
Uh-huh.
of the vial.
Without
So I
that
was
leaving there.
outrageously overdosed. I would have
Yeah.
outrageously overdosed the patient. And I plugged it into the IV, but didn't give any. And just then again, the attending shows up, realizes immediately what's going on, walks over and grabs the patient's arm to prevent the IV from running, to make sure that the IV didn't go into the patient, get any of the nitroprusside. So
Yeah.
it was two episodes as a fourth year student doing anesthesia that scared the crap out of me, but made me really fall in love with the idea of doing anesthesia.
Oh, it's incredible. Isn't it funny that something that could terrify you so much is what draws you in?
Yeah, I decided this is something I need to know about.
You
Um,
could save a life someday.
yeah, and so that was the first two introductions I really had to anesthesia. Um, so then I applied for residency and I got accepted to Mass General, which I thought was a great program, and I decided to take that opportunity. And I remember we started in a rolling start date. There was not everybody started July 1. They started people in a rolling date, so you didn't have all the rookies there at the same time.
Hmm.
So I started in September, um, and and I had a great group of colleagues who started with me, and I became friends with them for the whole residency program. I forget all their names, but anyway, great group of people, and really
How many years was
say
anesthesia at that time?
it was 1 year of medicine and 2 years of anesthesia.
Okay.
And I did my medicine internship at Miriam, actually.
Oh.
I did a month or two of surgery, but I was primarily a medical intern.
Hmm.
And that was okay. That worked out well. And I liked being here in Providence because my family was here and we had just had a new baby.
Mm.
So my oldest son was born when I was graduating from medical school.
Wow, that's a busy time of life for you.
Right. The month I graduated medical school is when our son was born, our oldest son.
Intern year must have been very, very busy.
Very busy. My wife did a lot of work that year. And
Uh-huh.
my folks helped out too, which was great because they were living right around the corner. So that was great.
Were you born in Rhode Island?
Yeah, born and
Okay.
raised. My parents are born and raised. So I'm one of the
Uh,
few people who is really a Rhode Islander in our department.
yeah, yeah, that's awesome. And then so you went to MGH and then decided to come back to Rhode Island after that.
Yes, it was a little more complicated than that. After MGH, my 2 years, I decided to do a cardiac fellowship, cardiac anesthesia fellowship.
Hmm.
So I had to wait around for about 6 months because there wasn't an opening at the Mass General until the following, I guess it was summer or whatever. And so I did a vascular fellowship in the vascular anesthesia fellowship at Mass General for about 6 months. And then I was an attending at the Mass Eye and Air Infirmary, which was right next door, to make some money. I did that for 6 months.
Mm-hmm.
And then I started my cardiac fellowship. And during the cardiac fellowship, I used to moonlight at Cambridge City Hospital, which is now just called, I think, Cambridge Hospital, which was fun. And I enjoyed making the money because it was, relatively speaking, good extra money. And we
Yeah,
were
yeah.
allowed to do that at the time. So that was good.
Was Boston expensive back in the day too?
Yes, Boston was
Yeah,
expensive.
it's still very expensive.
But what was neat was I got to take care of some really sick people and got some great experience. I remember one night I was on at Cambridge, and I was doing a ruptured AAA, and just as we're finishing that, a crashing C-section comes in. So I remember like running like crazy from the
Uh-huh.
patient that I dropped off in the ICU, then to the emergency C-section.
Wow. Were you solo practice at this time, or were you supervising CRNAs or residents
No,
there?
I was by myself.
Wow. Wow.
I was a cardiac fellow at the time,
Okay.
but I was by myself those nights when I was moonlighting.
Yeah.
So the point is, I got to do some really scary things, which again was a good experience and taught me a lot of stuff. But fortunately, I survived, and the patient survived, so that was all good, well and
That's
good.
great. What did a cardiothoracic fellowship look like when you went through it?
So there were 3 or 4 of us. I don't remember the exact number. There were 3 or 4 of us at a time. We had 3 cardiac rooms at the general every day, and we did probably about 1,200 or 1,000 or 1,200 open hearts each year. So we got lots of exposure. And I was lucky enough to work with some great attendings. One was a guy named Ed Lowenstein, who was one of the first guys who did high dose narcotic anesthesia for cardiac anesthesia.
Mm-hmm.
And he was a great guy, brilliant guy. And I got to work with Dan Philbin's dad. You know the Dan Philbin here in
Yeah,
EP
yeah,
Lab?
yeah. Mm-hmm.
His dad was a cardiac anesthesiologist at Mass General, and in fact was chief when I finished up my fellowship.
Huh.
So that was great. And he was a great guy as well.
Yeah.
And there was a guy named Demetrius Lapis, who was an old time guy, a Greek guy,
Uh-huh.
who was spectacular. This guy could using a Swan-Ganz catheter, he could tell you everything you wanted to know about the patient, including where they were born and how old they were. So I mean, it was unbelievable what this guy could learn from a PA catheter.
Uh-huh.
And so that was great. Great teaching, great clinical experience. The only thing that was not great was the surgeons.
Mm.
They were a pretty nasty crowd by and large.
Mm-hmm. How'd you get by?
I survived. I kept my mouth shut,
Uh-huh.
which took a little work, and I survived. But by and large, they were not such nice people, the cardiac
Mm-hmm.
surgeons.
When did echocardiography come out in your career?
While I was an attending at Rhode Island,
Okay.
so much later, probably 10 years later, I came in 86 to Rhode Island, and I'm guessing it was not till the mid 90s that we started doing echo.
Do you remember how that sort of shifted cardiac care in the OR?
Well, initially, not all the details, but initially it was used in mostly just valvular cases,
Uh-huh.
and it was done with the cardiologist coming down to help us. So initially, the cardiology attending would come and put the probe in and look, and we would, look over their shoulders, kind of thing.
Mm-hmm.
And then over the next few years after it first started, we became more proficient. And I remember taking courses and reading textbooks, and eventually taking the board. There was a board exam for echo,
Mm-hmm.
which I remember taking out in Vancouver one year, which was great because immediately after the exam, which was really a tough exam,
Uh-huh.
I went skiing up in Whistler.
Amazing.
So that was great. But that was probably in the mid 90s or mid to late 90s, I'm guessing.
Okay.
And then later on, it became, routine. But initially, it was
Mm-hmm.
just used on the sick valve patients.
Besides echocardiography, what do you think has been one of the biggest technological advances that you've seen in anesthesiology?
Well, clearly, ultrasound, absolutely.
Okay.
Propofol, end-tidal CO2, because when I first started, we didn't have end-tidal CO2. LMA, what else? Sugamidex.
Mm-hmm.
What else? I'd say those are the biggies.
Mm-hmm. And what brought you back to Rhode Island Hospital? Was it to be closer to your family?
Pretty much. So when I finished my training, we could have either gone out to Chicago, which is where my wife was from, or I got an offer to be a chief of anesthesia at Barnes in cardiac anesthesia at Barnes because I knew the chief of anesthesia there.
Mm-hmm.
And so I turned down Barnes because I didn't feel I was quite ready to be chief at that age.
Mm-hmm.
And I turned down Chicago because the commute would have been about an hour and a half each way. And I decided Providence sounded pretty nice because it was only a 10-minute commute from my house to the hospital.
Yeah.
And again, being close to my family was a good thing, and that was okay.
Mm-hmm. And how
But
long did you stayed here your entire career, correct?
yeah, so I came back in 86. I started in 86. I was the 13th physician within our anesthesia group at that time. Arthur Burt had started about a month or so before I did. So he and I were the two young guys who started cardiac anesthesia at Rhode Island.
Uh-huh.
But prior to that, it was all done by whoever the first call doc was. The first call anesthesiologist would do the cardiac cases. And there were one or two nurse anesthetists who were proficient in cardiac, and they were there routinely. So we did away with that system and decided to start a formal cardiac anesthesia team. So Arthur and I started that, and we started doing about, when we were at our peak, we were probably up around 800 hearts a year over those next 10 years or so, because this was from the mid to late 80s to the mid to the late 90s, and maybe even later than that. And then we got up to about 5 or 6 cardiac people on the cardiac team at that point.
Hmm.
But initially it was just Arthur and I for quite a while.
So you must have been pretty busy then.
Yep, we were very busy. We
Yeah.
would do 2 or 3 hearts a day. And then later on we did more because we had 2 rooms routinely. And then Maslow came. I think Maslow came in the late 90s. I'm not
Uh-huh.
sure when exactly came.
Uh-huh.
And then other cardiac people came, and some people left, but Scotty McKinnon came. I'm trying to remember other people. Who was it? Carl Schwartz was on the heart team at one point. Hugh Cowden. Who else? I think that was about it. Anyway,
So are you in our current department, have you been here the longest?
there's one person who's been here longer than I, and that's Nuri Ralphie, Dr. Ralphie.
Okay.
Do you know him?
I have not met him, but I've seen the name on the schedule.
So Dr. Ralphie is probably in his early 80s,
Uh-huh.
and he came here in the late 70s, and he was here as a resident and then stayed on as an attending,
Huh.
and he's been here ever since. But I think he's officially retired actually now.
Okay.
But he's been doing
ECTs?
ECTs for probably about 15 years.
Got
So
it.
stopped doing other anesthesia other than the ECTs probably about 15 years ago.
Was he here when you were a medical student at Brown?
To be honest, I don't remember. I assume he
Yeah.
was, but I don't remember
Yeah.
because I was a
Yeah.
medical student. I graduated medical school in 81.
Mm-hmm.
So he probably was here at that point.
Gotcha. One thing I wanted to cover with you was how you were created the opportunity to create your own medical student rotation for the Brown medical students.
Well, there were 2 things. Number one, there was there was that rotation already set up. And Donna Kucharski, I don't know if you know Donna Kucharski. She was an anesthesiologist at the Miriam. She did the rotation with a couple of other people. And I came in and I decided I wanted to do that. So I said to her, let me join with you and do it. And she said, great. And then shortly thereafter, she said, you know what, you do it. I'm not going to do it anymore. So I took over and fell in love with that. I thought that was a great thing to do, teaching one-on-one.
Uh-huh.
Rather than, I'm not a big proponent of lecturing, but I like teaching one-on-one. I think you can learn a lot of stuff that way.
Yeah, absolutely. And it seems like all the students that I talk to love it. Actually, when I talked to Dr. Asher, when I did one of his interviews, he mentioned doing the rotation with you when he was a Brown medical student, and that being one of the reasons why he wanted to go into anesthesia.
I didn't know that.
Yeah, yeah.
That's
Pretty
wild.
cool. Pretty cool. Do you remember when, I guess I mean, obviously it wasn't that long ago, but when we were transitioning to having the residency program here,
Yes,
were you excited?
nervous.
Yeah. What were you most nervous about?
Whether we could have enough people who like to teach,
Hmm.
because I felt there were a lot of people who really weren't great teachers or didn't want to teach,
Uh-huh.
and there was some resistance, I think, among those people. I was willing to do it, and because again, I like teaching,
Right.
but I was nervous that there wouldn't be a core group that could teach. And then the other
Yeah.
question was, were we going to have enough good material and enough good residents and enough, ICU stuff, etc. But Gil did a great job putting this together. I must admit, he did a
Mm-hmm.
great job.
Mm-hmm. And I feel like you've clearly taken on an active teaching role for the residents.
I
There's
tried to.
when I think about whenever I think about sort of the things that you've instilled in me, it seems to resonate with a lot of different residents because you have certain things about the way you teach and the way you practice that you feel very passionately about. And you could probably guess some of the things that I'm going to rattle off here.
I'm sure I can guess.
So I'm going to go one by one and ask you where the importance of it came from and why you like to teach about it. And the
Okay.
first one is going to be ketamine.
So ketamine, I had experience many, many, many years ago with high dose ketamine in cardiac. We used to use high dose ketamine in cardiac. We used to put like 200 milligrams in a burette and let it run in for induction. And I was worried about some of the side effects like hallucinations and agitation and etc.
Hmm.
So then I decided, well, what about low dose ketamine? So I started doing low dose ketamine probably about 20 years ago. And in my day to day practice, I realized that I could get away with much less narcotic. And I hate narcotics, quite frankly, in terms of what they do to people.
Hmm.
So I try to minimize narcotics. I mean, we still use narcotics all the time, but I wanted to minimize narcotic use.
Hmm.
The other thing I found out was every time I gave fentanyl on induction, the next thing I had to do was give phenylephrine after the tube was in. 2 minutes later, I had to give phenylephrine. If you didn't give the fentanyl on induction, you didn't have to give the phenylephrine afterwards.
Hmm.
And I said, this is crazy. So that was many years ago. I did that. I started doing that.
Okay. My second one is magnesium.
So magnesium, not quite as old as ketamine. Magnesium, I'm not sure how I first started using it, um, but I remember somebody talking about arrhythmias, tachyarrhythmias, and magnesium being a drug for tachyarrhythmias. So I first started using it for tachyarrhythmias, and I really fell in love with the drug for tachyarrhythmias. And then I decided, well, what about its antihypertensive effects, which were uh, pretty apparent as soon as I started using it. And then basically switched over from beta blockers because I used to use beta blockers instead,
Hmm.
labetalol or metoprolol or something like that for
Hmm.
hypertension and trop, and went to magnesium. And based on some of the analgesic properties and some of the fact that it's not a bronchoconstrictor, it's a bronchodilator, I thought was very good. And it's a
Hmm.
great drug for rhythm issues, I think, for tachyarrhythmias. So I just
Yeah.
started doing that. What I found is that if you have an idea and it's not dangerous, I mean, obviously you got to be careful, but you should pursue it.
Hmm.
And even though it's not a randomized prospective controlled study, it's okay to try it and see if it works. And then you really should be doing the prospective randomized studies to prove the point. But unfortunately, in our practice, that wasn't easy to do, and I basically didn't have enough time to do that. So, which is
Hmm.
disappointing, quite frankly.
Hmm. The next thing I'm going to mention is being able to get an EJ.
Just do it. I just started doing it because I
Uh-huh.
remember in the old days doing central lines with the EJ. And I said, well, if it's so easy to do a central line with an EJ, although it's not that easy because you got to go around the corner at the clavicle, it's certainly easy to do a short line, just a peripheral EJ. And I think it's a great thing to know how to do, and I recommend it highly.
Has it bailed you out of difficult situations?
Absolutely,
Yeah.
absolutely. The point is, it's easy to do, relatively speaking. It's not dangerous. It's readily accessible. You can draw blood from it. You can now you got it's not it's a little tricky because sometimes you have to pull back on it to make it run. But EJs are great, and we should be teaching it and promoting it more.
And the last thing that I always hear in the back of my head in your voice is the Miller blade.
The Miller blade, Bobby Rivera, who was a nurse anesthetist with me, remember one of the cardiac guys I mentioned from early on in my career? He
Yep.
used to use a Miller 3 on everybody. And he said, "You got to learn this thing." I said, "Okay, Bob, show me." And he taught me how to use a Miller blade, both 3 and 2. And I will tell you, that saved my butt many, many times.
Hmm.
One more thing, ballotting the cuff. We didn't talk about
Yes.
ballot the cuff.
Yes, ballotting the cuff.
Another thing that should be done, I think, routinely, because it's easy to do, cheap, and very important.
Absolutely. I do that all the time now.
I can't tell you how many times I've walked into a room and found the tube in too deep and asked to deblot the cuff, and they said no.
Mm-hmm.
And it's just, I don't know why they don't, but they don't. People don't.
Yeah, it's once you realize what the exact feeling is of feeling the cuff being ballotted, then it's a very simple thing to do right after
It takes
intubation.
practice. I agree. It takes practice.
Yeah. What else?
What else?
Do you have any? That's all I got.
Disconnecting the adapter from the endotracheal tube and putting alcohol wipe and sticking it back in.
I've had that happen before.
The Z-shaped stylet for the video laryngoscope.
Mm-hmm.
I did this with a medical student. I wrote a letter to the editor. I think I forget the name of the publication, but we wrote a little letter. He wanted to do a project. So I said, let's look at this. And then one of my colleagues at the Miriam, a guy named Agarwal, Suchit Agarwal, was one of the anesthesiologists. He said, let me show you something, because we were having trouble one day with the video laryngoscope. So he showed me how to do it. I said, this is great. We got to publish this. He said, it's going to save people's lives.
Yeah.
So I wrote a quick little letter to the editor with the medical student. We published that, and that turned out to be another helpful thing.
That's incredible.
So I think that's the list, pretty much.
I think that's the list too. Well, we have a few minutes left here, and you've sort of come towards the tail end of your career. We had our professionalism award like about a month ago now, where you were honored and recognized for being a really integral part of this department, and really in such a young residency program, so foundational, I think, in everyone's experience and everyone's education. So I want to thank you from the bottom of my heart, and honestly, probably on behalf of my co-residents, for being such an incredible teacher and really creating a great residency program and a great foundation for us all going forward.
I'm very honored. Thank you so much. I will tell you, it's been a great joy. There've been some tough times, but all in all, I've been very impressed with the crowd, with the as I said, with the residents and with the faculty stepping up. And I think Gil has done a great job, as I mentioned, in terms of getting the program going. And as I said, I've been pretty lucky, because this was my home, and I got to make it a really nice place, and it worked out very well. So I've got 2 more weeks, and then going to hang up the shingles, or hang up the stethoscope for at least a while. They think they're asking me to come back for the week in February for school vacation week, so I may end up doing that.
Okay. What's your last official day?
The 20th, January 20th.
Okay. All right. Perfect. That's when I'm going to put this out, on your last day.
Great.
I want to leave it with 2 questions.
Yes, Ken.
The first one is, how did you know it was time to hang up the stethoscope? And then the last question is, what are you going to do with all your free time now?
When was it time to hang up the stethoscope? Well, I'll tell you, I started thinking about doing it when I was 65. I'm now 71. And I still enjoyed doing the work, but I was getting more and more tired. My skill set has gone down a little bit, not terribly, but a little bit. It's been noticeable to me. And I want to go out on a high rather than after I've fallen apart, kind of thing. So I started thinking about it when I was 65. I said, I'll wait till 70. A couple of years ago, when I was turned 70, it was COVID, and I said, all right, I'll hang around, because I got nothing else I really want to do now.
Mm-hmm.
And so that's why I decided to wait another 2 years. So that's essentially why I decided to do it now.
Mm-hmm.
What I'm going to do is, my mom is now in her late 90s, and I need to take some time to take care of her.
Mm-hmm.
And my grandkids are in their, early elementary school age, and they're 6.5 and 4. So I want to spend some time going down to Philadelphia and spending more time with them. I want to do some skiing. I want to do some golf in the summer. I want to do some learning Spanish, because I think Spanish is an important thing to know. And it's interesting. I was thinking about, I was reading yesterday the recent anesthesiology journal, the Green Journal. And I was reading some of the papers and said, this is still fun looking at what they're publishing and asking the question, how does this affect my career, my professional career in terms of changing my practice? But I encourage everybody to be active in terms of their thinking about how to make our practice better, rather than just accepting whatever the textbook tells you. And that's what makes the whole thing fun, because I don't think I would have done this for 40 years if it weren't fun.
You've definitely made it look like fun, even at the tail end of your career.
Thank you.
I don't think I've ever seen you in a bad mood when you're at work, so it must feel like every day is vacation when you enjoy what you do.
I agree. It's been great. What are you going to end up doing? Did you decide?
Yeah, I'm doing
cardiac.
I'm doing critical care next year up at
critical care in Boston.
Yeah. Yep.
Good luck to you. That's a great career.
Thank you. I appreciate it.
All right. Anything else?
I think that's it. Thank you so much, Dr. Rotenberg. This was awesome.
You're welcome.
This was a blast talking to you.
Thank you again. Take care.
Of course. I'll see you later. Goodbye.
Bye-bye.
Thanks for listening to this episode of Behind the Drapes. If you like what you hear, be sure to hit the subscribe button so that you can get all the new episodes of the show as they drop right to your homepage. If you really, really like what you hear, be sure to rate and review so that other people can find the show easily, and also tell a friend so they could check it out too. Special thanks to all the guests who come on the show and help make my job a lot easier, and hopefully make an entertaining time for you guys to listen to. We'll see you next time.